Um, um, Professor George and everybody, I would like to welcome you to today's nephrology fireside chat. And my name is Dr. Egina Francis Makwabe. I'll be moderating this session together with Dr. Pascal Rugajo, who is a nephrologist and physician working with Muhimbili University College of Health Sciences. And also he's the head of the Department of Internal Medicine at University of Muhimbili. Together, we'll also be moderating this session with Dr. Jonathan Wala, who is a nephrologist and physician working with Aga Khan Teaching Hospital in Kenya. So on behalf of Kenya Renal Society, Uganda Kidney Foundation, Nephrology Society in Tanzania, and Burundi nephrologists, I would like to welcome you all into today's nephrology webinar. And today's topic is very, very important topic. It's a nutrition topic. And the topic is importance of nutrition in chronic kidney disease. So before I invite Professor George Abraham, who will be covering this topic, I would like to welcome Dr. Rugajo, who knows Professor George very, very well, to introduce the topic, and then we'll invite the speaker, Professor George Abraham, to continue with his presentation. Dr. Rugajo, Pascal, you are welcome.
Thank you so much, Mr. Chairperson, Dr. Egina Makwabe. Do you hear me?
Yes, we can hear you very, very well, Dr. Rugajo.
Excellent. I have the trepidation and honor to introduce a mentor, a great educator, and a very passionate person with nephrology training, Dr. Georgi Abraham. Dr. George Abraham is a professor of medicine, Institute of Medical Science. He is the director of nephrology at Madras Medical Mission in Chennai. He is an adjunct professor of Indian Institute of Technology, Madras. He is an international advisor to the Royal College of Physicians, London. He's contributed to Kumar and Clark Clinical Medicine. He is a coordinator and host examiner of MRCP US thesis in South Asia. He is an executive member of SAARC Nephrology, Urology and Transplantation. He's the founder trustee of George Foundation, Kerala Kidney Foundation, and Tenka Foundation, of which he has received several awards. He is founder president of Peritoneal Dialysis Society of India. He is editor-in-chief of the Indian Journal of Peritoneal Dialysis, South Asian Journal of Peritoneal Dialysis, Urology and Transplantation. He has received numerous awards, both national, regional, and international. The most notable being the International Society of Nephrology ROSCOE Robinson Award for Excellence in Education in Nephrology and Medicine. Personally, I have been lucky enough to have interacted with Professor George for the past 1 decade. I have attended his training in Chennai as a nephrology student. I have met with him in the ASN Nephrology Conference in San Diego in 2015. We invited him as a chief guest and as a principal nephrologist in our NESOT conference 2 years ago in Zanzibar. On personal terms, I also know him as a great dancer. He danced very nice with my wife in Zanzibar that night. With that introduction, I have the honor and privilege to introduce Dr. George Abraham to take us on a very important topic today on the importance of nutrition in kidney disease. Dr. George Abraham, the floor is yours. Karibu sana.
Good evening, my dear brothers and sisters from Africa. Respected Egina Makwabe, Professor Pascal Rugajo, Dr. Jonathan Wala, and my dear friends from Africa. It is a great pride and privilege for me to address you regarding the nutrition in chronic kidney disease. because it is a big important, and we need to have some understanding of nutritional aspect. Even though we differ in culture and race, the African community is different from the South Asian community, but we all have to eat and we have to feed our patients to make them well and to save their lives. So let me move on to the first slide. I am going to talk about the importance of nutrition in chronic kidney disease to the weekly fireside chat African Healthcare Network. This is the Madras Medical Mission Hospital, Chennai. I am in the opposite building, sitting in my office in the 3rd floor. And this is the Pondicherry Institute of Medical Sciences in Pondicherry, which is about 150 kilometers south of Chennai. So this is the outline of my talk. I will show you an illustrative patient and talk about the physiology of nutrition, then pathophysiology of malnutrition, and management of malnutrition.
Yes.
The objective of nutrition in chronic kidney disease is to prevent malnutrition, to reduce the uremic symptoms as a result of nutritional therapy, and to slow down the progression of CKD. These are the 3 primary objectives of nutrition in chronic kidney disease. I'm sorry about this busy slide. I'm showing you a patient. This is a 37-year-old South Indian lady with CKD stage 5, weighed 40 kilograms. She was 48 to 50 kilograms 2 years ago. She also has menorrhagia. She is not married. The body mass index was 17.6. She is underweight. And this is the body mass index for South Asians, 18.2 to 22.9. And I am sure for African community, it is 24.9, upper limit. She was on native Siddha medications for 6 months in the hope that she could slow down the progress of a chronic kidney disease. When she came to the hospital, her hemoglobin was 2.2. We had to transfuse her and it came to 5.8. Urea was 77 milligram, creatinine 6.18 milligram, total serum protein was 5.9, and serum albumin was 3.3 below normal. The normal serum albumin is 3.5 to 5 grams per deciliter. These are the anthropometric measurements done: mid-arm circumference, mid-arm muscle circumference, tricep skin fold thickness, body cell mass using a body composition monitoring, and the abnormalities were face angle was low. This is a measurement we do and come to a conclusion after using the body composition monitoring. Normal for this lady should have been 4.5 to 6.6. Her hand grip strength was low, 9 kilograms on the non-dominant hand, because on the dominant hand she had an IV line, and the edema, extracellular water, factor to total body water was 0.42. Normal should be 0.36 to 0.39. So she had excess fluid. And we did a CT scan of her being in between having fever. We showed bilateral pleural effusion as shown in this, more on this side compared to this side. And she also had paratracheal lymphadenopathy, and the Mandu test was positive. And being India has 18% of the world population, but has 25% of the TB load all across the world. So we started our anti-tuberculosis treatment. This is nearly 4 months ago. She has gained weight. She is doing better. She's on maintenance hemodialysis, and she takes anti-tuberculosis medication. So this cartoon shows a wasted individual like her, a normal individual, and an overweight individual. So I am going to speak about the physiology. The essential nutrients are macronutrients such as carbohydrates, proteins, fats, and lipids and water. And the micronutrients are shown here: vitamins, minerals. So you have calcium, chloride, magnesium, phosphorus is going to be high as chronic kidney disease progresses. Potassium is going to be high. They have fluid overload with the extracellular sodium water accumulation due to excessive salt intake. And they also need chromium, manganese, iron, copper, zinc, selenium, and a lot of other microminerals. So does the higher means higher fat or higher muscle? So let me take you through that. I'm sure you would say that this man is not very muscular. He has gained quite a bit of fat. So going again into the physiology, this shows the energy expenditure kilocalories per day. So this bar graph with the different colors show you, and here on the vertical axis you see the calories, and the energy expenditure is shown here. The basal metabolic rate, which is about 60 to 75% is for the basal metabolic rate. Then physical activity is 15 to 30. So if you are a marathon runner like in Africa, or if you are a bodybuilder, or if you are a competitive sports person with chronic kidney disease, you will have more energy requirements to meet this. And diet induced is about 7 to 13, and others are 2 to 7. So healthy subjects, energy requirements range from 35 to 40 kilocalories per kilogram body weight day, depending upon the physical activity. So the nutrient composition of a normal adult, this is total body water and total body solid. The extracellular water is 20%, the intracellular water is 40%, and the fat is 15%, protein 15%, and minerals 10%. So looking at the water, brain and heart are 73% water, lung has 83% water, skin has 64% water, muscle and kidneys 79 to 80% water, bones have 31%, and adipose tissue has only 10% water. So fat and muscle play different roles in metabolic homeostasis. The extracellular water is 20, intracellular is 40, fat is 15%. They are the energy storage. Compartment volume depends on energy intake. As I've shown the cartoon in this, they have more fat in that particular cartoon. Protein is 15%. Muscle has 60% of the protein. Viscera has 20%. Connective tissue 15%. And the remaining protein is 5%. And the muscle is a tightly regulated protein compartment, stores glucose as glycogen. So the carbohydrates are different chain length and composition. You have the monosaccharides such as glucose, fructose, and galactose, disaccharides such as sucrose, polysaccharides such as glycogen, starch, and fiber, and glucose is the key sugar in human nutrition. So proteins are composed of amino acids and are the primary source of protein, nitrogen. So for each protein, you require 20 amino acids. So chains of, this is an amino acid structure. There's a carbon and NH3COH and H. And protein uses normally reserved for protein biosynthesis, peptide hormone production, and maintaining organ function. Also for energy production during conditions such as hypermetabolic catabolism. So if you are consuming less energy in terms of carbohydrate, and if you don't provide energy, the muscle will break down and produce energy, giving rise to muscle waste. So all proteins are synthesized from 20 amino acids. Essential proteins are 9: leucine, valine, isoleucine, methionine, tryptophan, lysine, threonine, phenylalanine, and histidine. Non-essential are alanine, aspartic acid, cysteine, serine, tyrosine, glutamic acid, glycine, and proline. Conditionally essential are glutamine and arginine. So this shows you CKD and protein storage. Protein is present in the cellular pool, in the plasma, and also, so when you look at that, you eat about 70 gram protein a day, a 70 kilogram person, and it gets absorbed into the gastrointestinal tract, goes into the free amino acid pool. It is about 62 grams, of which 0.3 gram per kilogram per day moves into the plasma protein, which is about 0.5 kilogram totally. And then 300 gram is albumin, and the rest is other protein. And it also moves for protein in cellular pool. So it moves, it is nearly 10 times that of this 0.3, 3.4 to 4.7 gram per kilogram per day, gets into the cell, synthesizes protein, and amino acids are synthesized by ribosome to protein, broken down by proteasome into amino acid. They get into the pool, and the nitrogen excretion per day is about 11.2 grams. 1 gram of nitrogen is 6.2 grams of protein. So dietary fat comes in different types, and some are more beneficial than others. So they are saturated fatty acids on the blue bars, and then monounsaturated fatty acids on the red bars, and polyunsaturated fatty acids on the orange bars. and then sterols in the blue bars, which is mainly cholesterol. The polyunsaturated fatty acids are either omega-3, which are alpha-linoleic acid, eicosapentaenoic acid, and docosahexaenoic acid, and omega-6 are linoleic acid and arachidonic acid. So this is a cartoon of the kidney. The stages are shown there, stage 1 to stage 5. And then kidneys are important in fluid electrolyte acid-base balance, removal of waste, blood pressure maintenance, erythropoietin production, vitamin D, active form of vitamin D production, keeps the bone healthy, is involved in calcium, phosphorus, vitamin D, PTH, and FGF23 and homeostasis, maintenance of body pool of amino acid. 15 to 70 gram of amino acid are filtered and 98% are reabsorbed daily. And it is also involved in the homeostasis of glucose and insulin. So this is a book which we have multi-authored in India, and it talks about the management of malnutrition, CKD. It is not only for South Asia, you can use for anywhere in the world for developing countries. And then this is a picture taken from that. This shows the entire gastrointestinal tract from mouth to the anal canal, and the stomach, the duodenum, the jejunum, the ileum, and the colon, and the functions of what are the absorption pattern here, and what are the secretions. Pancreatic enzymes and polypeptides are secreted, bile is secreted, and intestinal brush border enzymes are secreted for digestion. And so almost all the substances are reabsorbed as per the needs from different parts: duodenum, jejunum, ileum, and the colon is mainly involved in the reabsorption of sodium and potassium and vitamins, vitamin K formed, and water. And it gets through the lacteals into the bloodstream, and then it circulates in the body. So healthy life for CKD patient. So these are 2 kidneys. It shows you about the food, shows you about the exercise you have to do, and the sleep you need, good sleep, and the fruits and vegetables you have to take. And so all these are important in kidney care and for kidney well-being. So let me go take you to the pathophysiology of malnutrition. The major metabolic steps in deficiency state disease: well-nourished individual who goes into an individual at risk, then malnourished individual. So either due to inadequate intake of food, impaired absorption from the gastrointestinal tract, or increased nutrient losses from the body either through diarrhea and malabsorption or through the kidneys, depletion of tissue levels and body stores. This leads to altered biological and physiological functions, deterioration capacity to function normally, clinical symptoms, morbidity, and mortality. So this is shown in dietary survey, because a nutritionist can do a dietary survey depending upon the need of the patient, either every 3 months, 6 months, or even more often when you are on dialysis. Then biochemical and physiological studies such as serum albumin level, pre-albumin, and various other parameters, signs and symptoms, inability to function, and they will develop symptoms, and vital statistics and mortality. So what is protein energy malnutrition? It's a lack in supply of sufficient energy or protein to meet the body's metabolic demands as a result of either an inadequate dietary intake of protein, intake of poor quality dietary protein, increased demands due to disease, or increased nutrition losses. What is sarcopenia? This is a patient with protein energy malnutrition, and this is a muscle fiber. You have shown the muscle fiber. It is covered with a perimysium. There are blood vessels there to supply the oxygen. There's a fascicle covering the muscle fiber, and endomysium and epimysium. So you have epimysium, perimysium, and endomysium. So sarcopenia is a progressive and generalized loss of skeletal muscle and strength, and it is strictly correlated with physical disability, poor quality of life, and death. Look at it. This is a sarcopenic patient. What is frailty? Frailty is a clinically increased vulnerability resulting from aging, associated decline in reserve and function across multiple physiologic systems, such that the ability to cope with everyday or acute stressors is compromised. So let me take you to the mitochondrial function. We all know that this is the cartoon of a mitochondria. So it has got a two-layer cover, an outer layer and an inner cover, and it has got ATP synthesis is the most important thing in mitochondria. There is mitochondrial DNA as shown here, ribosomes are shown here, inner membrane is shown here, outer membrane is shown there, and ATP synthesis and free radical protection. So what you see is this is a fused mitochondria. Fusion increases mitochondrial mass, and then fission increases mitochondrial number. This is fission. So both should go hand in hand, and so this will lead to more biogenesis of mitochondria, and the mitochondria which has become unnecessary, they undergo mitophagy and degradation. So what are the functions of mitochondria? In health, ATP production for contraction of muscle, cellular metabolism, and in abnormal, in chronic kidney disease, systemic inflammation and oxidative stress, muscle wasting, impaired growth of new muscle fibers, suppression of protein synthesis in chronic kidney disease, stimulation of protein degradation through the ubiquitin proteasome pathway. In CKD5, you have low mitochondrial volume, higher BCL2 adenovirus interacting protein, mitochondrial swelling, intracellular lipofuscin granules are increased, and mitochondrial DNA is decreased. So carnitin is very important in the transfer of long chain fatty acids to mitochondria. So they should get into the mitochondria, the long chain, for subsequent beta oxidation. And then carnitin also binds acyl residues deriving from the intermediary metabolism of amino acids and help in their elimination, functioning as a scavenger. So I just want to show you this recent findings and inflammation and mitochondrial function. So it is shown here where the tumor necrosis factor alpha, when you have normal, CKD progressing, and CKD5, so you have more tumor necrosis factor protection. And when you look at the interleukin 6, the same applies, controls CKD 3 to 5, maintenance hemodialysis patient, and then you look at the reduced factor to oxidize C1Q10 ratio. So controls it is high, and then as you reach CKD 3 to 5, it is low, and the ratio is very low when in maintenance hemodialysis patient. And when you look at intramuscular adipose tissue, IMAT stands for intramuscular adipose tissue, and in control it is less, and as the CKD progresses, it becomes more. So this is a CT scan, a normal skeletal muscle of the thigh, and this is the one which is showing with CKD. You can see the fat, white is fat. There is significantly increased fat in maintenance hemodialysis patient. And when you look at the mitochondria, see the mitochondria shown here, and the numbers are much less when you have chronic kidney disease with on dialysis. So what uremia leads is to oxidative stress, inflammation. It leads to mitochondrial dysfunction, accumulation of intramuscular adipose tissue, and physical dysfunction, frailty, and physical activity is decreased. And this is a cycle of events. And unless you correct it with the nutritional factors or taking care of the chronic kidney disease, you won't be able to reverse it. So factors influencing nutrition status are depression in dialysis patient or CKD patients. And this is especially important in the COVID times. We have the extraordinary times all over the world, and people are finding it difficult to get food, and they go through depression irrespective of their financial status. Altered taste sensation is one of the symptoms said about COVID, but this also happens in chronic kidney disease, increased catabolism and decreased anabolism, amino acid abnormalities, metabolic acidosis, because as the GFR falls, the hydrogen ions are not excreted, and the bicarbonate falls below 22 milliequivalents, hormonal derangements, insulin resistance, and increased PTH. Sorry about this busy slide. Malnutrition, inflammation, cachexia complex syndrome. So you have hemodialysis patient and peritoneal dialysis. So the causes are uremia, uremic toxin. There are comorbid conditions such as diabetes mellitus, cardiovascular disease, endocrine disorders, nutrient loss via dialysis, giving rise to protein energy, malnutrition, and decreased nutrient intake. And on the other side, You have decreased clearance of inflammatory cytokines, as I have shown earlier, oxidative and carbonyl stress, volume overload, dialysis-related factors all lead to inflammation, leading to malnutrition, inflammation, cachexia syndrome. And then kidney disease wasting, decreased albumin, increased CRP and cytokines, and then deficiency, weight loss, decrease in BMI, and then on the other side, you have a hyporesponsive anemia due to erythropoietin deficiency, decreased quality of life, atherosclerotic cardiovascular disease, which leads to increased hospitalization and mortality. So I just want you to look at that, the new aberrant interorgan and interorganism communication contributes to uremic syndrome. So gut plays a major role in uremic generation of uremic toxin. So this is symbiosis. Symbiosis means 85% of the 100 trillion microbe in the gut are of healthy, and only 15% are unhealthy. So what the gut tells the kidney, so this is called, you have the metabolites shown here, and the pyramids are signaling molecules are shown there, and then you have other circulating small molecules as shown here. And the kidney sends crosstalk with pancreas to brain to heart through all these pathways, muscle, liver, and the gut. When you have symbiosis, it works in perfect orchestrated function. So when you have chronic kidney disease, kidney injury, diminished tubular secretion of the toxins. As a result, the gut microbiota is altered. There is dysbiosis. So instead of having 85% having good mycobacteria, well, bacteria, you have a reversal of that because of kidney failure. The gut becomes more permeable, and then so this leads to defective signaling to brain, to pancreas, to heart, to muscle, and to the liver. And as a result, you develop complications, that is disordered interorgan and interorganism communication. This is steady state interorgan and interorganism communication. So let me show you this. So when you have chronic kidney disease, the intestinal microflora, CKD, and insulin resistance leads to cardiovascular disease, protein energy malnutrition, insulin resistance, dysmetabolism, inflammation, endotoxin production, dysbiotic gut microbe. They produce peak resol and indole acetic acid, which are uremic toxins and absorbed from the gut, which perpetuate again these things, immune dysregulation and infection. So the human gut is host to 100 trillion bacteria with an enteric reservoir of over 1 gram of endotoxin. So when you look at the gut again, kidney function, you have comorbidities, medications taken through the mouth, dietary anorexia and low fiber in the diet, constipation. This leads to decreased motility, decreased protein degradation, decreased absorption because of edema. This will lead to increased proteolytic bacterium flora, as I already dysbiosis, toxin generation, and then prebiotic and probiotic, can they help with that? I feel that definitely yes, prebiotic and probiotic can help with that. So this will lead to mucosal injury of the gastrointestinal tract, translocation of bacteria and toxins, inflammation, cytokine release, immune suppression, leading to increased cytokine production here and increased half-life, decreased cytokine elimination, increased cytokines, increased uremic toxins, and endotoxemia. So sorry about this busy slide. Mechanism leading to protein energy wasting is shown in this busy slide. CKD leads to vitamin D deficiency, altered glucose homeostasis, increased activity of mitochondrial uncoupling protein, inflammatory cytokines, increase in leptin and desacetylghrelin, and nutritional restrictions leading to decreased nutrition intake, anorexia leading to decreased need. Increased glucocorticoids also play a role in uremic malnutrition. Then activation of the ubiquitin proteasome activity, growth hormone IGF-1 resistance, insulin resistance, proteolysis, increased resting energy expenditure, and protein energy wasting. So where are the manifestations? You can also get the micronutrients that most commonly present with cutaneous findings include B vitamins such as riboflavin, niacin, pyridoxine, biotin, and vitamin B12, C, fat-soluble vitamins A, E, and K, minerals such as zinc, iron, copper, selenium, and essential fatty acids. So unless you have a balanced diet, you can develop changes in the hair, nails, and skin as a result of micronutrient deficiency. Now, carnitine. I already spoke about carnitine. This is a study done by us, both in hemodialysis and in peritoneal dialysis patients. We found that carnitine deficiency was present in 68.4% of the patients, whereas in hemodialysis, it was 64.3% of the patients had carnitine deficiency. So let's move to what do we do? How do we assess? This is the body composition monitor we do in one of our peritoneal dialysis patients. This is ended here. I have shown in my first patient illustrative case what we have done with the BCM. And then you look at the mid-arm circumference. You take 2 points. One is acromion and the olecranon. And in between that, the hand is flexed at 90 degrees. And then the hand falls down and you measure it with a tape. That is mid-arm circumference. And the skin fold thickness, you can measure by triceps and biceps skin fold thickness, correlates very high with underwater weighing or hydrostatic weighing. The standard error of 3 to 4%. Hand grip strength, this is what we do regularly, is an index of general health and as a screening test for the integrity of both upper motor neurons and function of the motor unit. So DEXA is expensive. We have done a lot of DEXA, but then the cost is a major factor. It cannot be used in everyday practice. So I just want to submit these things. The intake, you have the source, you have the loss. The intake can be noticed by dietary recall and symptoms by a trained dietitian. The stores are by anthropometry, serum albumin, DEXA, and BAA. And then losses are through the urine, normalized protein nitrogen accumulation in a steady state, not in an unsteady state. And functional state is measured by hand grip strength. So this will all give rise to a subjective global assessment, which I'll talk in the next few slides. So prevalence of malnutrition and nutritional issues in CKD patients. I'm not going to talk about India because it is not applicable. We have separate data. So malnutrition wasting is common in CKD, as approximately 18 to 75% of the patients with CKD undergoing maintenance dialysis therapy show evidence of wasting. High malnutrition rates in CKD patients, 24 to 48 in pre-dialysis patients, 18 to 75 in dialysis patients. Risk for malnutrition increases as CKD progresses. Protein energy wasting is common in patients with chronic kidney disease and is manifested by lower levels of serum albumin, prealbumin, sarcopenia, and weight loss. So there are two methods. One is called screening and assessment are fundamentally different. Nutrition screening recognizes signs and symptoms of nutritional problems, identify patients who are at risk of poor nutritional status, and require further assessment. The assessment is evaluate the clinical condition, diet, body composition, and biochemical data. So this is a little more complex, and classify patients by nutrition status as well or undernourished. So medical history should include in any nutritional assessment the comorbidities like diabetes, hypertension, infections, cancer. What are the medications they are taking? Because in India, patients take a lot of other alternative medications, functional limitations, ability to walk, run, get up, or play. Residual renal function is very important. Renal replacement therapy characteristics, whether it is transplant, dialysis, either PD or hemodialysis, and above all, socioeconomic and cultural factors. Because socioeconomic, we fall in the same South Asia and Africa, but in cultural factors, we differ, the African community and the South Asian community. The physical examination and interview are central to nutrition assessment. It should look for peripheral edema, oral problems such as dryness, glossitis, candidiasis, caries tooth, and then problems in the gastrointestinal tract, changes in skin, eyes, nails, and hair, and interviews, dietary intake, and loss of appetite. So subjective global assessment is widely used in CKD. There is a history part, weight loss, reduced dietary intake, GI issues, functional capacity, physical exam, muscles, subcutaneous fat, edema, ascites, clinical judgment. You have a well-nourished patient, you have a patient that risk for moderately malnourished and severely malnourished. The advantages are it is robust and widely used, quick to administer. Limitations are requires training based on clinician, and it can be reproduced. So next is the malnutrition inflammation score can help in diagnosing growth. So you need an SGN with a body mass index and serum albumin level and transferrin level. Scoring is each MIS components has 4 levels of severity. Final score ranges from 0 to 30. MIS above 5 is considered malnourished. Advantages are can help identify presence of protein energy wasting. Limitations are required training like SDA, need lab values such as albumin and transferrin, and MIS may be used without transferrin also. Now, let me take you malnutrition, chronic kidney disease. Increased prevalence of protein energy wasting, malnutrition, worsening of kidney. Stage 1, stage 2, stage 3, stage 4, and stage 5. Malnutrition, protein energy wasting present from 24 to 48%, and in ESRD in up to 75%. So let me take you to the dietary protein intake recommended as per CKD. Stage 1, 2, stage 3A, stage 4, and stage 5. So the GFR is, eGFR is over 60. It is 1 to 1.2 kilogram per day. CKD is stage 3A, lower normal, that is 0.8 gram per kilogram per day. And CKD is stage 4, low protein, 0.6 to 0.7 gram. If it is less than 0.6 gram you are taking, that is very limited protein intake. You may add essential amino acids or keto analogs, but long-term studies haven't shown any long-term benefit of using very low protein diet. Even though short-term studies are there, the jury is still out there. So CKD stage B, low protein intake, 0.7 to 0.6 gram. The CKD stage 5, not on dialysis, you lose low protein. So dietary protein requirements in stable, non-nephrotic, non-catabolic CKD patient is shown in this slide. So keto analogs, there are a lot of talk about keto analogs. What are they? They lack an amino nitrogen. Once you take keto analogs, they take the endogenous nitrogen present in the body, convert to essential amino acids in liver, muscle, intestine by transamination. The keto analogs utilize dietary nitrogen, recycle nitrogenous metabolites, improve nitrogen, amino acid, increase amino acid metabolism, protein anabolism, and reduction in blood urea. So depending upon the cost, you may have to use it because some of the preparations are very expensive, and so you may have to use your judgment, individualize the patient therapy to use keto analogs. Now, this is a very important slide I want you to look at. I will explain to you. There are two groups of cohorts. One, the eGFR is less than 90 ml. The other one is more than 90 ml. They are into 1, 2, 3, 4, 5 groups on both sides. And when you look at the eGFR, following the eGFR, this is the one with the eGFR of less than 90 ml per minute. And this is shown the urinary urea nitrogen gram per hour. So this is normal. And when you increase the protein intake to 30 to 105 grams, there is definitely fall in GFR. So when the protein intake is low, the GFR is stable. So in those who are above 90 ml per minute, despite changing the protein intake, there is no fall in the GFR. That's what it shows. Urinary urea nitrogen. So it's a very important thing, showing that as the GFR falls, you may have to restrict protein. So the role of kidney in glucose homeostasis, the kidney is considered as two separate organs. The renal medulla is characterized mainly by glucose utilization, and the renal cortex is responsible for glucose release. Three different mechanisms. One is by gluconeogenesis, glucose uptake from the blood for its own energy requirement, reabsorption into the general circulation from glucose, glomerular filtration rate. You know that by the SGLT2 and SGLT1 transportation. So lipids, the dyslipidemia, there is increased serum levels of triglycerides with high levels of very low density lipoproteins, ApoB, decrease in high density lipoprotein, and ApoA, cholesterol high in proteinuria patients, that is nephrotic syndrome patients. CKD experience a secondary form of dyslipidemia, that mimics the atherogenic dyslipidemia in insulin-resistant patients. ACE inhibitors and ARBs and statin therapy have a remarkable antiproteinuric effect with a significant improvement in renal function. So what are the uremic toxins? They are small water-soluble molecules with a molecular weight of less than 5,000, urea and phosphorus. Dialysable. Middle molecules are over 5,000 daltons. Microglobulin is one of these. And then you have the protein-bound compounds such as CMPF, IS, PCS, then organic acids, and indole acetic acid. So appetite stimulant. A lot of the patients do have decreased appetite and they may require appetite stimulants. We use mainly megestrol acetate. These are available. And also you can use serotonin agonist, cyproheptadine. Then cannabinoids and anabolic steroids such as oxandrolone have been used anecdotally to increase protein intake in severely malnourished PD patients. Now, nutrient recommendation CKD, this is pre-dialysis, hemodialysis PD, energy 35 kilocalories per, and 60% should be carbohydrate, 30% fat, less is protein. Hemodialysis below 60 years and above 60, below 60 years 35 kilocalories ideal, and above 60 years 30 kilocalories of ideal body weight. PD, same that of this. Protein intake, pre-dialysis 0.6 to 0.8 and very low protein, VLDP, I don't advocate that. Hemodialysis 1.3 to 1.4, PD 1.3 to 1.5 kilogram per day. Sodium 2 to 4 grams, 1 to 3 grams, and PD you can increase it because of the continuous removal of salt and water. Potassium less than 1 millimole per kilogram if elevated per kilogram. So 70 kilogram person can take less than 70 millimoles, less than if elevated hemodialysis patient. Not usually an issue, but it can happen. If you take 10 mangoes a day and do peritoneal dialysis, you can have hyperkalemia. Phosphorus 80 to 1000 milligram day plus binders is elevated. We always look at protein phosphorus ratio because we need to give the patients protein and phosphorus. So those with low phosphorus and high protein are the one we. So phosphorus protein ratio is important when you prescribe diet. So this is what is given here, and urine output and the fluid intake should be depending upon your urine output, and PD depending upon your ultrafiltration and residual renal function. So nutritional assessment of hemodialysis patient conserves for protein and energy malnutrition, spontaneous oral intake moderately below target, counseling from a dietitian and oral nutrition supplement. This could be commercial also, no improvement, intradialytic parenteral nutrition. Then if you have spontaneous oral intake, severely below target or critical illness, you have to give them enteral nutrition, and no improvement, you have to give them total parenteral nutrition. So enteral nutrition in COVID critically ill patient, and the enteral nutrition should be initiated early, standard isosmolar polymeric formula, starting at a trophic. Trophic means small volume, 10 to 15 ml per kilogram per day, like milk, advancing as tolerated, monitoring GI intolerance, hemodynamic instability, and metabolic derangement. Feeding using prone position is necessary in patients who are hypoxemic, extracorporeal membrane oxygenation, lower threshold for switching to parenteral nutrition in case of aspiration, escalating vasopressor support, use fiber additives and probiotic organisms, no recommendation for micronutrient supplementation, assess risk-benefit ratio to patient health, to patient and healthcare professionals. So the malnutrition confusion, you can see that it is a very complex issue. So my concluding slide, malnutrition is highly prevalent in CKD patients. Pathophysiology involves carbohydrate, fat, protein, micro and macronutrient abnormalities. Understanding and assessment should start at the early stage of CKD and CKD dialysis and in transplant patients. Combined efforts by nutritionists, nephrologists, family and psychologists, and we all our hand together for saving their life and also to provide better nutrition to our patients. Thank you, my African brothers and sisters.
Oh, thank you, Professor George. That is great presentation, and we really appreciate for the knowledge that you have shared with us. So, Professor George, it's a time for questions.
Yes.
And I think you'll be receiving questions from direct from the audience. Yes. And please, if you are ready, you can ask straight to Professor George. He's ready for the questions.
Whether there are any questions in the box, there is a box.
Yes.
Okay.
Yeah, but let me ask you, maybe I can ask one question, Professor George. In patients who are on hemodialysis, they can easily get malnutrition if we are really strict on dietary control. But which one would you like? Would you like to have a patient who have normal BMI, or the patient who have higher BMI? Because I remember there is one study which
yes.
showed the reverse epidemiology, that people with higher BMI tend to tolerate hemodialysis better as compared to patients who are normal, who have normal BMI or low BMI. What's your comment on that, Professor George?
Yes, this is European data, developed country data. I do not know about the African community. They said that patients who come with a higher BMI on hemodialysis have longer survival compared to somebody whom I show you in the cartoon. You have the wasted man and also the normal BMI person. So my understanding is that those who have higher BMI, I also have a number of patients with higher BMI without comorbidities, they survive longer on hemodialysis compared to somebody with a lower BMI. Hello.
All right. Okay. Thank you. Thank you, Professor George.
Dr. Georgi, I have one question. Quite often, now today there are papers like from Dr. Kalanta Zode to show that albumin of 46 gram%, the mortality is really low as compared to anything less than 40. And quite often to reach that target, you see, it needs a lot of protein intake, and we sometimes restrict protein. Even 1.4 may not be enough. What are your comments?
Yes, see, the Asians, South Asians, it is very difficult to reach that target. Most of our, I told you my patient she had 3.3. We rarely ever see in our patients a serum albumin of more than 4. It is so. I think that he is looking mainly at a group of Americans who are eating a lot of meat and other protein substitutes. And so we need to do, we have some studies done, Indian studies done, to look at the malnutrition in hemodialysis patients, depending upon the socioeconomic status, and it is already published. The most important thing one should remember is that when you take 70 gram protein for a 70 kilogram patient, the 35 gram should be of high biological value protein, because we don't eat high biological value protein. This comes mainly from meat, fish, and egg. So a lot of people do not do that, and as a result, you find their albumin levels to be low. So we did a study in here, and we published that already in renal failure some years ago. The majority of the patients do not have 50% uptake of high biological value protein.
Yes.
Dr. Veri has a question. Professor Veri has a question.
How are you?
Thank you. I'd like to know what are the standard supplements to give patients on dialysis, hemodialysis, and peritoneal dialysis as a standard on a regular basis.
Right. See, we tell them peritoneal dialysis patients in India get the impression we have two types of community. One is the vegetarian community and the other one is the non-vegetarian. Even the non-vegetarian community do not take protein intake like the African community or the Caucasian community. So we tell them to eat peritoneal dialysis patient. Most of the time you eat a normal diet. And if you have no residual renal function, we tell them to restrict salt and water, because we need an ultrafiltration of about 1 liter or up to 1.5 liter, they can eat more salt. So they eat normally the peritoneal, but the hemodialysis patient, most of our patients, nearly 50% of them are a little over around twice weekly hemodialysis. So when they are on twice weekly hemodialysis, they eat less, they have issues with taste buds. And so what we do is either we tell them, because we have a nutritionist going around, and we also do a BCM every month in our maintenance hemodialysis patient. So we know that how much is the muscle mass, how much is the fat mass, how much is the lean body weight. So what we do is that the dietitians go around and speak to them, and usually there is some impact, we'll see beneficial impact. Other patients who can afford, we give them commercial preparation from the multinational companies. I'm not here to endorse anybody, but we use a lot of NEPHRO-HB in our patients.
In terms of vitamins,
we give them,
B,
yes.
C,
Yes,
vitamin.
We all give them vitamin preparation with zinc, because zinc deficiency, also we had a paper which we published many years ago. So we give them a vitamin B complex preparation with zinc, all of them.
This is Dr. David from Kigali.
Yes.
Yes, Dr. Joseph.
Yeah, I would like to thank Dr. Ibrahim for his presentation, but he has actually raised what has always been running in my mind. Seems to confirm it. Now, by the looks of it, chronic kidney disease, if you talk of malnutrition, especially protein malnutrition, it is actually a kind of delicate balance. You take a lot of protein, you cause damage. You reduce protein, you cause malnutrition. Now, the question that has always gone into my mind is, when do you restrict protein intake? When do you advise patients to increase protein intake? Particularly, you mentioned actually something on American diet. Generally, and the textbooks we read, written by American, basically from the West, generally their protein intake is very high. And again, but here you find, you talk of protein intake, and particularly of high biological value. In our environment, most of our patients actually, the source of protein is actually plant protein, rather than they get animal proteins, basically meaning it is a protein of low biological value. So particularly in an environment, I suppose in India it's probably about it's about the same. So it becomes very delicate when you advise patients to increase protein intake, and also when you advise patients to restrict protein, because you do your damned and you don't your damned. So basically, it seems that it's essential to individualize in a patient, and also to individualize in society. I would like you to comment on that.
Yes, as you said, individualization of dietary advice is very important in chronic kidney disease. Because I may like certain things. I'm going home now, it is almost 9:30. So my wife would have prepared some rice. I eat rice at night. And along with that, some fish curry or fish fry, and I don't eat meat. So I will have vegetables along with that. So the issue is that you need to individualize, and you need a trained dietitian to look at the dietary review of the patient, because we are not dietitians. Because we can only give some impression to the patient. When you see that, I have shown you a picture of a patient with severe malnutrition, who has only skin and bones. So depending upon the individual and the physical well-being, whether they are in the pre-dialysis stage or in the dialysis stage, you have to individualize and give them advice by a trained dietitian to make sure that they are adequately, they receive adequate protein, energy, nutrition, and trace elements as well as vitamins. At the same time, they don't overeat, so that I showed you that urinary urea nitrogen appearance in those who are less than 90 ml per minute or more than 90 ml per minute. So if those who have less than 90 ml per minute, if you eat more protein than what is recommended, your GFR will fall. So this has to be taken into consideration when you take care of the patient. I agree with you 100% that it has to be individualized, and there should be, if somebody is wasted, they need more dietary counseling, more often. So this can be given by a trained dietitian. So most of the time what we see even in India is we have very few trained nutritionists in renal care. We have a society also, but we are trying to teach more people how to look at chronic kidney disease patients, both in non-dialysis and dialysis and transplant population, and how to help them with that. So what we do in our unit is, we have a BCM. I said we were lucky enough to have it, and we do work with the BCM, and we do that. I have a paper which we published some 5 years ago, looking at body composition monitoring in both hemodialysis and peritoneal dialysis patients, and over a longitudinal period, and seeing that, you know, depending upon the overnutrition or undernutrition or hypervolemia or hypovolemia, their survival depends on that.
Thank you. Question? You've alluded to the training of renal dietitians. Can you tell us what you would recommend? In Kenya, we have, we are wishing to start the training on renal nutrition on a diploma course, also a renal nutrition course, as a master's course. Would you recommend that we go ahead with this? Or would you rather that we combined it with other non-communicable diseases? What is the structure in India, and what would you like to recommend for us?
Absolutely necessary. A renal nutrition is different from a non-renal nutrition in terms of advising a patient. They understand the patient better, and then they give the advice. So you should go ahead. You should be the leader, Kenya, Nairobi, wherever, leader in having nutritional courses, which can be degree or diploma. In our institution, medical mission, we have a course, and this should be enabled, and it should be sustained to produce more nutritionists who are able to advise patients with the renal nutrition. I congratulate you for this initiative.
Oh. Can I ask a question, Prof?
Yes.
Yeah, thank you very much for a comprehensive presentation, Prof. I just had two questions. The one question that I have is, what is the likelihood of patients getting refeeding syndrome, especially those who are malnourished, when you optimize their feeding? And secondly, would you kindly please elaborate more on the keto analogs? What patients should get it? When is it basically advised? Is it during patients who are at ESRD, or patients who have got CKD, or both, or only dialysis patients? Thank you.
Right. Now, the first thing is refeeding syndrome. See, refeeding happens mainly when you have, I showed you that wasted lady in my presentation. Body mass index is low, face angle is low, and she has more body water, and her serum albumin was less than 3.3 grams. So the refeeding we did was slowly, and not putting a nasogastric tube and all those. So the refeeding was slowly. So her physical well-being improved, and she is able to, I told her even to dance. So she's a dancer. So if you do it slowly, it doesn't happen. But if you have a very sick sarcopenic patient who is hospital bound or home bound, and if you do the refeeding, introducing everything, all of a sudden, you may come across refeeding syndrome. So we do it slowly. We have trained dietitians, so they do it slowly. Number two, the second question was about, what was the second question? What was the second question you had?
It was about the keto analogs, Prof.
Keto analogs. I don't use keto analogs personally. The reason is that the multinational companies sell it as a very high price in India. Indian keto analogs are there, but the data is lacking with regard to the beneficial effect of keto analogs with low protein or very low protein diet in slowing down the progression of kidney disease. So if you have a rich man who can afford that, I don't mind, let him take the keto analog. But if it is a patient who is from the lower socioeconomic status, I don't advocate taking keto analogs. I advocate because one egg costs about 5 rupees. Now it has gone to 8 rupees in India. One egg will provide nearly 8 grams of protein. So whereas keto analogs cost almost 5-fold or 6-fold for a single tablet of keto analog.
Thank you, Prof. I just wanted the confirmation from you. So I'm on the right track there. Thanks.
Prof, can I ask a question quickly?
Yes.
the images you showed of the muscle where you were losing mitochondria, is there any role for any antioxidant type medication? And then a second question is how vital is an in-body machine? Would you recommend most nephrologists use one?
Well, I got one. I'm very happy with that because this body composition monitoring, for example, you are in Nairobi, you can have one machine which can be shared by all people. Tanzania, you can have one machine in Dar es Salaam which can be shared by a number of people. It is an essential component of dietary assessment so that you can have a record of what has happened today. Maybe after 3 months you can do that. So body composition monitoring. In addition to hand grip strength, mid-arm muscle circumference, and also skin fold thickness. So I'm sure that that will definitely help you in empowering your dietitians also to look at the patient critically and support them. What is the next question you asked?
It was about antioxidants and the role.
Now you asked whether antioxidants, definitely it may have some role, antioxidants. But I don't think that it plays a major role because when you have uremia, the mitochondria, I have shown you that CT scan picture. Mitochondria are less, they are defective, and they don't function normally. There may be some role. I don't say there isn't, but that is not the most important thing.
Thanks, Prof.
All right, Prof, there is one text message from Dr. Jonathan Ngumi from Tanzania, Muhimbili National Hospital. He's asking what are the types of protein in that a patient with CKD is recommended in patients with CKD, especially red meat.
Yeah, I saw that question.
As majority of our patients,
no,
yes, you have seen that question, yes.
A lot of our patients in India, they take red meat also. So it all depends on the high biological value protein. Because if you are not eating something, I said I don't eat meat. So I need to get high biological value protein, so I eat the other thing. Some others, they only eat red meat. It can lead to hyperuricemia, which is a part and parcel. But then you need to have the high biological value protein because your muscle breakdown is, in a dialysis patient, is nearly 2.5 kilograms every year. Just the muscle breakdown. So you can take, I don't say that you should look at that as a deterrent for the nutrition of your patient.
All right, thank you. I think that's very clear to Dr. Ngomi. So another question, please.
Yes, from Pascal Rugaja now.
Yeah, Pascal, welcome back.
Okay, yeah. So thank you so much, Professor Georgi. It is always very insightful to listen from you. And today you have really shared with us your experience and a lot of education. So I'll just ask a very naive question. We have been trained on, most of our books are written in American diet, and understandably, patients with CKD or end-stage renal disease are preoccupied with dietary restrictions. From time to time, they'll ask you something you have never read, like a local food stuff, whether they should eat or not. What is the best approach to when answering such questions?
Yeah, a patient likes certain food, but when you have a dialysis patient or patient in stage 4 or stage 5 CKD, the issues are we giving a food substance which has a high potassium, hyperkalemia, or it can worsen the metabolic acidosis, or these are both the life-threatening conditions, or does it contain a lot of sodium which can retain the water, because each 9 millimole of sodium will retain 1 liter of water. So if you take extra salt, you are going to retain that. So the food substance, you need to have some knowledge of the local food substance. And then you have to give the advice, a broad advice, but I would suggest that it should be a dietitian who is taking care of it. So hyperkalemia, metabolic acidosis, then sodium retention, and then any other complications which can develop as a result of the food, like gastroenteritis, or you are eating a food which can produce more dysbiosis bacteria, gut bacteria. So these are some of the things you should look and individualize the nutrition advice to patients.
Just a little comment.
Can I ask a question also, Prof?
Yes. Who is that?
This is Rose Opio, Nairobi, University of Nairobi.
Yes, Rosa, tell me.
Okay, thank you very much, Prof, for that wonderful presentation. Now, we all agree that nutrition is very important and very key in the management of chronic kidney disease. And patients, however, face several challenges ranging from acceptability of the new diets to poor access to the recommended foods, as well as mixed nutrition messages from some of the nutritionists as well as some healthcare workers. And some of these problems are actually due to lack of national nutrition guidelines in some countries. I think this one is also related to a question that someone has just asked. The lack of the national nutrition guidelines in some of the countries, the guidelines that are based on locally available and accessible foods. And therefore, because of this, you find that adherence to the diet prescriptions is generally low in most countries all over the world. And recently, we just completed a study that confirmed this same scenario in Kenya. Adherence to the diet prescription is low. There's a lot of over-reliance on international guidelines. And so the use of locally available foods in the prescription it's a bit of a challenge, and that challenge is transferred actually to the patients themselves, that makes them end up being confused on whether to take the prescribed diets or not. So I'm just wondering, what's your take on this? Because at the end of the day, the poor adherence, the low adherence to the diet prescriptions just makes the management of these patients even more challenging and more difficult. Okay. Thank you.
See, basically, we were also following all American guidelines. It has got its own limitations and also its own challenges. Because we eat different food. I also lived in North America and England. So there the food was different. Now the food is different. So you cannot blindly follow what the Americans say. Even Kam Kalandar, you know, he is a very good friend of mine. There are regional differences in the food you eat and in the food you cook and the ingredients you add to that. So these are different in different countries. So you should have, as I showed you, the book which we have written for South Asian countries, including, you know, a lot of people from Pakistan, not only India, we have involved people from Pakistan, Bangladesh. So we have put together something for our people. So you need to have nutritional guidelines and nutritional prescription for your patients, not to blindly follow what the Americans or the Europeans say. That would be my advice. And you need to have a good nutrition team who knows about the local practices and put into practice as per, because the nephrologist is the leader there in most of the day. It is not the nutrition. So the nephrologist, Rose, should involve nutrition people and also the family. And it should be, that's what I said, family, nephrologist, nutritionists, all should come together and put guidelines for the people of your country, of the African community, rather than blindly following what the Americans and Europeans are talking about and writing in their textbook and in their journals.
Just one comment, Dr. Georgi. Can I add on? Now, yes. The question, there are both Dr. Pascal and Dr. Opio addressed a very important point. The dietary differences exist between Kenya and Tanzania. Now, in Tanzania, there are very good food composition tables, the local food composition tables. So I would advise, along with guidelines that are going to be brought up in Kenya, I think you should have first a food composition table that is brought about there, and also look at a food compliance study to see what among the food and the composition compliance will be high. So that with high biologic value protein will actually aid in a good guideline development. So food composition table is available in Tanzania. don't know if it's in Kenya.
Somebody is asking how many hours sleep you require. I would say that I would like to sleep for 9 hours. I need to get that because otherwise I feel that I have sleep deprived. So it all depends on the individual. But I think that minimum 2-3 hours is not sufficient enough. You should get good sleep of about 7 to 8 hours.
No, Wi-Fi.
Thank you, Dr. George. Can you please mute your mic, please? There's someone that we can't hear when Professor Georgi is talking. Please mute your mic. Okay, I think we'll receive one more question, and then we allow Professor George to continue with his duties. One more question, the last question.
Yeah, I have one question. Dr.
Yes.
Again.
Yes, Dr. Ntarindwa.
Now, going back to the issue of keto analogs and transamination, I would like to ask Professor George, is it recommended, how early should one start pyridoxine in CKD? I use vitamin B complex for my patients on dialysis, and actually when I do it, there's improvement of nutritional status. If I compare with those people that have not been on vitamin B complex that come from other dialysis units, let's mind one another. Actually, pyridoxine is pyridoxine pyrophosphate is actually a coenzyme for transamination, for converting the glucose into amino acid and vice versa. So, how strongly would you recommend, and how early should one start? How early in CKD should one start the use of pyridoxine?
Okay, when you look at the RDA for the B complex vitamins, it is 100% of the RDA you are recommended to take. Recommended daily elements. There are a number of charts for that. So I didn't show you how much is for peritoneal dialysis and hemodialysis. So 100% of the RDA you need for B complex vitamins, including pyridoxine.
Dr. Georgi, what is your schema of evaluating a patient on dialysis? Now, how frequently do you screen and how frequently do you assess? Because your experience will be very helpful.
Yeah, because we 3 nephrologists are there in our unit. So there is one person particularly in charge of dialysis. But we go to the dialysis unit, we see the patients every day except the last shift may be seen by the duty doctor, the 3rd shift. So, but our dietitians are there. They have been given task to take care of these patients and speak to them. So they do the BCM now once in 2 months. Earlier we were doing it once a month. And that report is passed over to us. So we know that, how much extracellular water and also the fat-free lean body mass. So that helps us a lot in coming to conclusion. Anemia management, it is also a part of the malnutrition. So most of the patients will require extra iron. We give iron sucrose, it is cheap here, 100 milligram or 200 milligram. And also some of the patients, we looked at the B12 deficiency vitamin. So we didn't see much of B12 deficiency vitamin. So anemia management, including iron, B12, and erythropoietin is a part of it. And so a dietitian plays a major role in our dialysis unit. You know that in CMC Vellore also, when we were there many years ago, that is the only institution which had, you remember that kitchen meal for the dialysis patient or dietitian coming. But so a dietitian plays a very important role in my unit in helping us to advocate right nutrition therapy.
Thank you for stressing that, Dr. Georgi. Thank you very much. The other thing, one last question is MIS. Do you use MIS? I mean, I find it very useful here
Yes.
in our preliminary work. MIS scoring gives you a very good idea. Besides the screening that we use MUST or SNAG, but we also use MIS now. A very good idea of how the patient is doing.
Because you don't have to use transferrin now. You need only albumin. So it is easy. STA plus albumin and the measurements.
Yes, correct. Thank you.
All right. Thank you, Professor George for great presentation. It was wonderful. And also I should thank everybody who participated in today's educational nephrology webinar. Just one announcement that the previous presentations on approach to, yes, Dr. George?
Pascal, I just want to comment. What is the effect of amount of vitamin A present in multivitamin given to SAARC? See, we don't supplement vitamin A in dialysis patients on patients in stage 5 CKD because they have enough vitamin A. So unless you have measurements done for vitamin A and deficiency, do not supplement vitamin A in CKD 5 patients or in dialysis patients. So that question came out on my screen. Hello. Hello.
All right. Okay. Okay. Yeah. Professor George, thank you very much. Yeah. So I think, Professor George, we have come to the end of our presentations today, our webinar. We really thank you for your time. Thank you for sharing your knowledge. Thank you for spending all the time with us, for answering all the questions. And also I should thank everyone who participated in this presentation. Specifically, I should thank Dr. Lloyd, our Chief Medical Officer. I should thank Dr. Pascal Lugajo and Jonathan Wara from Kenya. So just one announcement that the presentation that was done a couple of weeks ago on approach to acid-base disorder is out now. You can go to the hot box and then you can just get all the presentation at any time you want. So thank you very much. So see you next week. Thank you, Professor George. Yeah.
Good night. Good
Bye.
night.
Thank you so much, Dr. Georgi. Thank you very, very much for all the trouble and lovely presentation. We are sharing the slides with everyone who was asked as well. So thank you. There's a lot of information in that. Thank you very much, Dr. Georgi.
Good night.
Good night.